Good evening and a very happy Teachers' Day to all. On behalf of Pharma Division of Jagsonpal Pharmaceuticals Ltd, I, Dr. Deepika Chhabra, along with my teammates, Mr. Amit Saxena from Medical Services and Zonal Sales Manager, Mr. Rakesh Kumar, we are delighted to have your presence with us today. As the academic partner of this webinar organized by West UP chapter of ISOPARB and TMMC and RC Moradabad, Pharma Division of Jagsonpal Pharmaceuticals Ltd offers Divatrone, 10 mg tablets of dydrogestrone, LycoRed soft gels and LycoRed Preg sachet, and Maintane injections, among many other products. A warm and hearty welcome to all the esteemed faculty and attendees. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the Q&A box. Please note this webinar is streaming live on Facebook and the link is shared in the chat box. To refer to this webinar recording in future, please visit our YouTube channel, Jagsonpal Medical Insights. The national convener for today's program is Dr. Shubhra Agarwal, Professor, Obstetrician and Gynecologist at Tirthankar Mahavir Medical College and Research Center, Moradabad. We now request Dr. Shubhra Agarwal, ma'am, to kindly take the proceedings further.
Thank you so much. A great teacher affects eternity. She can never tell where her influence stops. With these words, here I wish a very happy Teachers' Day to all teachers par excellence present today with us on this auspicious occasion. I really feel blessed and honored to be a part of this webinar on this pious day with all the galaxy of stalwarts amongst us who took time from their busy schedule to shower their blessings on us. I join my hands and extend my sincere most welcome to our chief guest of the day with a majestic aura, true visionary, and impeccable academician, teacher of teachers, Padmashree Professor Dr. Usha Sharma ma'am. Na gurur adhikam tattvam, na gurur adhikam tapaha, na gurur adhikam jananam, tasmay Shri Guruve namaha. Meaning, I prostrate to that Shri Guru, who is the eternally true, austere, and absolute personification of Trinity, Lord Brahma, Vishnu, and Mahesh. I offer my deepest gratitude and welcome you, ma'am. Not everyone has the patience of a saint, a heart of gold, and dedication without end, but you do. With this thought, I hereby take an opportunity to welcome our guest of honor, North Zone Vice President, Dr. Archana Verma ma'am, because of whom West UP ISOPARB has gained its genesis and reached its zenith. She was a real guidance force behind this webinar to infuse the knowledge in the students in such an innovative way. Thank you so much, ma'am. I welcome you. Teachers are like gardeners who put all their efforts just to have the best bunch of flowers. With these motivational thoughts, I seize the opportunity to welcome our next guest of honor, Dr. S. Sampathkumari ma'am, an epitome of knowledge, amalgamation of diligence and benevolence. I welcome you, ma'am. जो दूसरों को प्रमाद करने से रोकते हैं, स्वयं निष्पाप रास्ते पे चलते हैं, हित और कल्याण की कामना करते हैं, और दूसरों को तत्वबोध करते हैं, उन्हें गुरु कहते हैं. With this phase in mind, I offer my salutation to the Nobel Guru, our next stalwart, President ISOPARB, Dr. Gangadhar Sahu sir, who is a ladder of success for others to climb up. I extend my deepest gratitude to you and welcome you, sir. विद्वत, दक्षता, अच्छा आचरण, पढ़ाने की कुशलता, बहुधा अभ्यास, चेतना और अनुग्रह, शिक्षक के ये 7 गुण हैं जो उन्हें महान बनाते हैं. और इसी के साथ मैं 2 ऐसे महान शिक्षकों का अभिनंदन करती हूँ, आदरणीय प्रोफेसर डॉक्टर माला श्रीवास्तव मैम और आदरणीय प्रोफेसर डॉक्टर रेहाना नजम मैम, जिनका प्रभावशाली व्यक्तित्व सारे विद्यार्थियों के लिए प्रेरणा का सतत स्रोत है. I welcome all the esteemed chairperson and panelists who will share their knowledge with us. We all have gathered on this day to recognize the effort, hard work of all teachers who burn like candles to lighten up their students. Thank you to all the galaxy of stalwarts for your presence. Now I request everyone to join hands and offer prayer to the Supreme Power who is holding us all together.
Shubham kurutvam kalyanam arogyam dhana sampadah shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute Shubham kurutvam kalyanam arogyam dhana sampadah Shubham kurutvam kalyanam arogyam dhana sampadah.
Now I request my co-convener, Professor Dr. Mala Srivastava ma'am, to kindly formally introduce our chief guest, Professor Padmashree Dr. Usha Sharma ma'am.
Thanks, Dr. Shubhra. It's a privilege and honor for me to introduce Dr. Usha Sharma, who is the teacher of teachers. And she has been a great passionate about teaching all the students around her. Madam has been the ex-Director General Medical Education, Uttar Pradesh. She is the principal cum professor of Gynae and Obstetrics, LLRM Medical College, Meerut. She had distinction in anatomy, physiology, pharmacology, pathology, jurisprudence, ObGy during her MBBS. And she got the President of India Medal for Best Medical Girl of India in 1965.
I think Mala,
We are all blessed to be having ma'am as a symbol of teacher, as a symbol of education, academic, everything. Madam has been awarded Padmashree by the President of India in 1985, performed 611 laparoscopic ligations in 24 hours at Aligarh in October 1982, which is a world record. Awarded a laparoscope by late Prime Minister Mrs. Indira Gandhi for outstanding fieldwork in 1982. Madam has got Indira Gandhi Priyadarshini Award, Hari Om Ashram Alembic Research Award, Dr. B.C. Roy National Award, Mahila Jyoti Award, Rashtriya Ratan Award and Gold Medal, Jewel of India Award, and late Professor D. Kutty Lifetime Achievement Award, FOGSI's late RB and Dr. S.N. Malhotra Award, Golden Educationist of India Award. Madam, we can go on and on and on for the entire evening.
Thank you so much. Thank you.
We are waiting to get words of pearls of wisdom from you, Madam. Over to you, Madam, for your wisdom, for your blessings. We are all waiting here for you.
Thank you very much, dear Mala, for saying such wonderful words for me. I do not know whether I deserve all this or not, but thank you very much, Mala and Shubhra. I really appreciate and always admire all the persons who are involved in ISOPARB. They are so active and so dynamic. So today, Dr. Gangadhar Sahu, our national president, a very dynamic and dedicated person of ISOPARB, and who is a speaker also today. And then guest of honor, our very lovely, beloved, down-to-earth person, Dr. Archana Verma, North Zone Vice President, as well as Dr. Sampathkumari. Dr. Sampath, मैं आपकी एक चीज से बहुत impressed हूँ. जब मैं morning, I am also very much fond of sending messages in the morning. और जब मैं संपत का मैसेज रोज पढ़ती हूँ फॉक्सी फ्रेंड में, तो I am very much delighted क्योंकि I am also a fan who believes in sending messages. So Dr. Sampath, you are guest of honor today. We really welcome you. And then National Coordinator, Dr. Shubhra Agarwal, and co-convener, Dr. Mala Srivastava, and our Master of Ceremony, Dr. dear Seema Varshney, who happens to be Secretary, West UP ISOPARB, and Dr. Reenu Goel, who is Treasurer and another Master of Ceremony, and Dr. Gangadhar Sahu, who is the first speaker, Chairperson, Dr. Vani Puri, as well as our expert is Rehana, and representatives from Jagsonpal, as well as my eminent gynecologists who have logged in today. It really gives me a great pleasure to be with you all on the occasion of webinar on a very important and though it is a common subject, but it is not very much discussed, hypertensive disorders of pregnancy. And it has been organized by ISOPARB West UP chapter, Dr. Archana Verma, Dr. Seema, Dr. Reenu, as well as along with the Tirthankar Mahavir University of Moradabad, Rehana, and I will not forget that it has been very well supported by our dear Mala Srivastava. Now, we all know at the time, and the best thing is that rather it is a matter of great pleasure that this webinar is being organized on a very auspicious day of Teachers' Day. And I always say one thing, that my real treasure is my students. My students all over the country, not only in the country, but outside the country are doing so well that I am really very proud of them. And I always request and I always pray God to bless them with success at every step of their life. And not only this, I pray God to give them strength so that they can impart their services to the humanity with honesty, sincerity, dignity, as well as with humility, because I feel humility is the best thing which a doctor should possess. And I'm really very happy that today many of my students are also listening to this webinar. And we are going to discuss today, as I said, it's a very important topic or in day-to-day practice, hypertensive disorders of pregnancy. And we know that it is a silent killer, both for the mother as well as of the fetus since ages. We have been able to conquer many diseases by right time screening as well as treating them or giving them the treatment which they need. And many times we really avoid the deadly complications which do not arise and we just save them. And if we go into depth of etiopathogenesis of PIH or preeclampsia, then we find that actually the main thing is that there are disorders of placental formation as well as there is invasion, which usually occur in the late first trimester of pregnancy or in early second trimester of pregnancy. That means that we have got enough opportunity to screen them and to provide them the necessary treatment so that we can prevent them. And then we can advise them for lifestyle modification as well as sometimes few drugs like aspirin. But here the main thing which we should always consider is that we have to balance between the maternal benefits as well as the fetal risk, which can have due to medication toxicity as well as uteroplacental formations. And this is what I feel, that actually the problem is that till now we do not have a single guideline which we can rely upon. And there are varied guidelines regarding at which blood pressure level we should give the treatment, when to stop the treatment, and what is the level of the blood pressure when we should make it that it should be like this, as well as the time of delivery. All these things are very, very important. And so updation of the subject is the need of the hour. And I will really congratulate Dr. Archana, Dr. Seema, the doctors from Tirthankar Mahavir University, Dr. Mala Srivastava, to organize this webinar on such an important subject, which will be very beneficial for every one of us. And we know that we will be listening today, I will say a person with knowledge, Dr. Gangadhar Sahu, who will be speaking about the hypertensive disorder of pregnancy, and as well as we will be able to listen to the various comments and the remarks from the worthy panelists. The panel discussion will be moderated by Mala as well as by Archana. And I'm sure that the deliberation today will go a long way in updating the knowledge of every one of us who are attending this. And I really congratulate, because this is a very important subject and mostly we come across with these kinds of patients. With these words, I wish this program a great success, and thank you very much, Archana and the whole team, for making me a part of such a prestigious program. Once again, happy Teachers' Day to everyone, and I wish you all a very healthy, happy and bright future. Thank you very much.
Thank you, ma'am, for your words of wisdom. And I hand over to Dr. Shubhra to carry on the next program.
Thank you, ma'am. I invite Professor Dr. Gangadhar Sahu, sir, who is President ISOPARB, to shower his blessings on us and say a few words.
My Bhumishta Pranam to Usha ma'am. My namaskar to everybody. Greetings from ISOPARB and blessings from Lord Jagannath. So many things have been discussed within this period about the hypertensive disorders of pregnancy, and we are going to start it on such a auspicious day, that is the Teachers' Day. Actually, it was the brainchild of both Archana madam and Mala madam to start such a postgraduate seminar, and we suggested that it should be started on this day, that is 5th September 2022, the auspicious Teachers' Day, so that we can spread, ventilate the knowledge and wisdom which you have gained by virtue of our experience and from the evidence-based studies to our postgraduates. As it has been rightly said, that a teacher can show you the destination, a great teacher, but not the route or the path. So, my dear postgraduates, do not expect that I will show you the path. I will show you the destination. You are to find out the path. Regarding hypertensive disorders of pregnancy and my experience of last 40 years, because I am a dedicated obstetrician working in a rural medical college, I have seen everything of it. So I have seen how the names have changed. Hypertensive disorders of pregnancy, then comes pregnancy-induced hypertension, then came also gestosis, again gestational hypertension, superimposed chronic hypertension, so and so forth up to preeclampsia, eclampsia, and whatnot. So this changing name, and now again it has come back to a completing a cycle, that is hypertensive disorders of pregnancy. So this changing name suggests the complexity of the disease. Similarly, the pathophysiology, rightly being pointed out, Usha madam, that when we are postgraduates, the pathology was lying with the placenta only. Without a placenta, there cannot be disease. That is in the late 70s. Then came that the placental bed or the blood vessels. So vasospasm was thought to be the most important etiopathogenesis of this condition. Then gradually we are becoming narrower and narrower, coming to the endothelial lining, not the whole vessels. So endothelium is a dynamic structure. So any damage to the endothelium can cause this type of syndrome, that is preeclampsia, eclampsia, hypertensive disorders. Now from cellular level, we are in the molecular level. starting from different oxidants to the genetic factors. So it adds only to the complexity of the disease. My first slide, please. So let us pray Lord Jagannath before proceeding to this topic. So because God cannot be everywhere, he made mothers. Mothers are the true living representatives of Lord Jagannath to take care of the ailing mothers who are dying of malnutrition, sepsis, hemorrhage, and hypertensive disorders. At the same time, Lord Jagannath created a special brand of physicians to take care of those ailing mothers. So those special brand of physicians are none other than we, the galaxy of the experts who are sitting here, the boarding doctors, the obstetricians. Thought that I should act with the objective of how to reduce the maternal mortality when now in the developed countries, it is emerging as the #1 cause of maternal mortality. So my principle of approach will be prevent the preventable if at all, delay the inevitable, treat if it is treatable, and refer in time if not possible, if you cannot treat, and always hope for a cure. If it cannot be cured, it must be endured. So that is the principle of my talk. So therefore, to reduce the mortality, I need a devoted obstetrician who will be the leader, a dedicated team starting from the registrar clerk up to the midwife and neonatologist, well-equipped institution, and the institution where such facilities are not there, the transportation facility should be there. If these things are being available, then we can reduce the maternal mortality. So overview, I have already told something. Prediction and prevention, I am not going to touch it in detail theoretically, but how to my approach to reduce the maternal mortality. On the side of the management, if the primary prevention, if we can early suspect that this group of mothers are suspected or are, vulnerable to have this disease, what should be our line of management? Next is early diagnosis and treatment. That is the secondary prevention, where we can treat the condition with medical management, with obstetrical management. And last one is the prevention of complications, starting from going to the eclampsia, to liver failure, renal failure, multi-organ failure, fetal compartment abnormalities, all these things. And the most critical period where the maximum number of deaths do occur is the peripartum period. So therefore, focus on just before labor, during labor, and just after labor. So with that, we can reduce the incidence of maternal mortality. So actually, the science or the subject is not complete without prescribing a postpartum contraception. So with that, I will conclude then. Next, please.
Thank you so much. Thank you so much, sir, for your pearls of wisdom and showering your blessings on all of us. It's a pleasure to have a teacher par excellence like you amongst us. Now, I would like to formally invite our guest of honor, very dynamic, the guiding force behind this webinar, Vice President FOGSI, President West UP Chapter ISOPARB, Dr. Archana Verma, ma'am. She is Advisor UPCOG, Organizing Chairperson UPCOG 2020, Past President Ghaziabad OBS and Gynae Society, Organizing Secretary North Zone Yuva FOGSI 2016, Organizing Secretary Midterm UPCOG.
Well, thank you very much. And Mala, and you did the wonderful job of telling us. And I'm really thankful to ISOPARB president. He's such a great and humble person. I just cannot, I've yet to see us so much brilliant and so much dedicated. And my thanks to and best wishes to all. And sir, we always need your blessings. We will always be happy to work with you, whether I am at this post or not, but I will not going to leave you now. We will be working and working with you.
I need whole lesson of the ISOPARB should be in the same platform. That's
yes, sir. So we are feeling very highly protected under your wings, and this is something very nice. And thank you, and Dr. Rehana and all the Moradabad team. I'm so thankful to you for calling the brilliant postgraduates. I'm very sorry that it's been somehow there was some confusion, and let you carry on. And because the whole the panel, I want to tell that whole the panel, and I'm going to listen to Dr. Ganga sir talk, and Vani as a chairperson, and she is actually president-elect IMA of Ghaziabad, and a very wonderful friend and very wonderful person. And everybody, thank you very much. And our chief guest Usha Sharma madam has said so much, and we are so much thankful to her. She is like our mother, she is our like guru and everything, and so we are so thankful. Thank you very much. And to please carry on this program. Shubhra, please carry on.
Yes, thank you so much, ma'am, for your blessings. I feel extremely honored and privileged to invite our next guest of honor, Professor Dr. S. Sampathkumari, ma'am, who is Chief and HOD, Muthukumaran Medical College and Research Institute, Chennai, FOGSI Vice President-elect 2022, Founder Secretary, Tamil Nadu Federation of OBS and Gynae. She has many awards to her credit. She has received IMA Doctors Day Award from IMA, FOGSI Dr. Durusha Distinguished Community Award, FOGSI Mr. N.A. Pandit and Mrs. Shelja Pandit Women's Empowerment. Has written various chapters in FOGSI textbooks and FOGSI journals. We invite you, ma'am, and shower your blessings on us, ma'am. So now I would like to invite my Master of Ceremonies for today, Dr. Seema Varshney, ma'am, a very dynamic, ever-smiling personality, Secretary West UP Chapter ISOPARB. I hand over to you, ma'am, for the first session.
Okay, thank you, Shubhra. A very good evening to all of you. I want to say something, some few lines for Teachers' Day. Guru Vishnu, Guru Devo Maheshwara, Guru Shakshat Par Brahma, Tasmi Shuru, Guruve Namah. Myself, Dr. Seema Varshney, Secretary West UP Chapter ISOPARB, welcome you all. मेरा शत नमन and अभिनंदन आज की चीफ गेस्ट डॉक्टर उषा शर्मा मैम, पद्मश्री डॉक्टर उषा शर्मा मैम, प्रेसिडेंट ISOPARB डॉक्टर गंगाधर साहू, and guest of honor Dr. Sampathkumari ma'am, and President West UP Chapter ISOPARB Dr. Archana Verma. आप सभी को और मेरे सारे सीनियर्स टीचर्स को सभी को शिक्षक दिवस की बहुत बहुत बधाई, बहुत बहुत शुभकामनाएं. And my gratitude to our torch bearer, very dynamic, hard-working founder president Dr. Archana Verma, who took this initiative with guidance and support of Dr. Suchita Pandit, Padmashree Dr. Usha Sharma ma'am, and Dr. NM sir as patron, which has led to an exceptionally strong team across the West UP to get all these cities like Aligarh, Agra, Saharanpur, Bareilly, Moradabad, and all other West UP cities. She has formed a platform under one umbrella, which we have named West UP Chapter ISOPARB, with the theme Challenges in Perinatal Medicine and Anticipate and Act. It was launched on 30th September 2020. And we are grateful to our past president ISOPARB, Dr. Usha Sharma, Secretary General Dr. Meena Samant, and current president, of course, with all blessings, support, Dr. Gangadhar Sahu sir, and Secretary Dr. Pragya Mishra, for their continuous support and guidance, as this is the platform which we can get maximum exposure to the knowledgeable field of perinatology and safe motherhood. We have targeted the best care for pregnant mother and positive outcome by scientific session by galaxy of stalwarts. I extend heartiest congratulations to our dynamic founder president, Dr. Archana Verma, to turning all the aspirants and plans in the action. We command your strong will and grit to take this chapter to new heights. My heartiest congratulations to Shubhra, Dr. Shubhra Agarwal and team Moradabad for organizing such a wonderful webinar today on a very important and clinical topic, hypertension in pregnancy, and on, of course, on this very auspicious day, Teachers' Day. Happy Teachers' Day to all of you. Now, may I start the academic session, first academic session.
Ma'am, Dr. Sampathkumari is here for if you would like to invite.
Dr. Shubhra, you can invite her.
Yes, ma'am. I would like to formally invite Professor Dr. S. Sampathkumari, ma'am, to please shower your blessings on us. Ma'am, please say a few words.
Shubhra, can you hear me?
Yes,
Yes,
ma'am,
yes,
very well.
yes.
Good evening to all. First of all, I thank Dr. Archana and the entire ISOPARB team for inviting me on the wonderful day. That is the Happy Teachers' Day. And my pranams to Dr. Usha ma'am. And I thank Dr. Gangadhar, Dr. Mala Srivastava madam, Dr. Archana, Dr. Seema, Dr. Reenu, and Dr. Rehana for organizing wonderful CME. And thanks to Dr. Deepika and Shubhra for a continuous call. So this is an important topic, hypertensive disorder in pregnancy. We think that it is a common, but still the maternal mortality, 12% is due to hypertensive disorder in pregnancy. Although 60,000 cases, maternal death worldwide annually is due to hypertensive disorder. And 5% of all pregnancy is HDP. We can have many predictors with the biomarkers and prevention. We can tell that calcium, vitamin D, like that and all, and management. But only one thing, that is the measurement of the BP in a proper way, with a proper curve, is the only diagnosis for hypertension, and early identification and treatment alone can prevent the complication. If there is no treatment facility in that institute, early identify and refer the cases to the higher institute where all facilities are possible. So this hypertensive disorder pregnancy is a very, very important disorder and which can save the life. So I thank the entire ISOPARB team for taking this topic, the common topic, and I wish the success for the webinar. Thank you. Thank you once again, Dr. Archana and the entire team.
Thank you so much, ma'am, for your pearls of wisdom. Thank you, ma'am.
Thank you, Dr. Sampath. Thank you so much.
Thank you, Dr.
Thank you, Dr. Sampath, ma'am, for your kind words. And now I begin first session, first scientific session of today, and which will be chaired by very dynamic, very hardworking Dr. Vani Puri Rawat. She's President-elect IMA Ghaziabad, and she's Consultant ObGy. She's North Zone Coordinator, Sexual Medicine Committee, FOGSI, Secretary GOGS 2018-19, Treasurer 2017-18, and Secretary IMA Ghaziabad 2019 to 2021. She's Joint Treasurer IMA UP State, and she's member of Cultural Committee. I invite Dr. Vani as chairperson for chairing the session of Professor Gangadhar Rao. Dr. Vani, please invite and welcome Dr. Gangadhar Rao.
I just want to say a small sentence. Guru Gobind do khade, kake lagu paye, balihari Guru aapne, Govind diyo milay. So happy Teachers' Day to my all teachers and my virtual pranam. I wish that I would have been there and touched your feet. Dr. Usha Sharma ma'am, Padmashree, Dr. Usha Sharma ma'am, who is a motivation for each and every junior and senior over there. Dr. Archana Verma ma'am, who has taught me, who has just held my hand and taught me how to work. And Dr. Gangadhar Rao sir, I pranam you sir, teachers of teacher. Dr. Sampathkumari ma'am, a senior FOGSian. Dr. Mala ma'am, I heard your so many lectures in Gangaram ma'am. So I have learned lot and lots from you all. Dr. Seema ma'am, I have learned lot. and Dr. Reenu ma'am, and I'm sorry if I've missed anyone. So first of all,
Moradabad team.
I'm कर रही हूँ अभी उसके लिए. So I'm privileged to chair this session, and that too, which is the deliberation is given by Dr. Gangadhar Sahu sir, such a senior person. I thank Dr. Usha Sharma ma'am, Dr. Archana Verma ma'am, Dr. Seema, Varshney ma'am, Dr. Reenu Goel ma'am, the team ISOPARB West UP, and TMMC and Research Center, all the dignitaries from there. I thank everyone, and let's start the session. So it's my privilege to introduce a great personality, Dr. Professor Gangadhar Sahu sir. He is a president, National ISOPARB, and is a retired professor and HOD, ObGy and Gynae, VSS Medical College, Burla, and Dean IMS and SUM Hospital, and Pro VC and SOA. And so this you have written your dream. I bow down you, sir. Your dream is to be a ladder of success for others to climb up. So that's the greatest thing, and so humble you are, sir. So I request you, sir, for your deliberation. Thank you very much, sir. The dice is yours.
So within this period of turbulence, actually, so I have crossed the first trimester of pregnancy by this time. So I cannot allow it to be a miscarriage. So rather, I have planned in this rest period how to approach my topic. My topic I will approach that for the hypertensive of disorders of pregnancy, what a postgraduate should know. I have changed my version now. A postgraduate should know what do you mean by the gestational hypertension. The gestational hypertension, by definition, is a condition only related to a placenta or pregnancy, which occurs in general after 20th weeks of gestation, when the blood pressure recorded is 140 systolic, 90 diastolic, at least twice, minimum of 4 hours interval. Number one. So if that is the case, then what you are going to do? The first thing is, already as it has been stressed, that correct measurement of blood pressure is mandatory for every postgraduate student. So there is no compromise. Sitting posture, straightened arm, right side cuff, with tucking, you just elevate the anxiety of the mother, record both palpatory, then both systolic and diastolic blood pressure. By that time, if it is raised, you can repeat it after 4 hours. So diagnosed it as a case of gestational hypertension. First problem is solved. But another confusion occurs. Can there be hypertensive disorders of pregnancy without hypertension? Can there be preeclampsia without hypertension? The answer is yes, because it is a disease of controversies. It is said that there may not be, clinically you cannot detect hypertension, but the pathological process of hypertension that continues, giving rise to multi-organ involvement, giving rise to thrombocytopenia, giving rise to renal complications with albuminuria, so on and so forth. So that is pathological preeclampsia that can be. Can there be preeclampsia without proteinuria? Again, yes. Earlier, it was mandatory that hypertension with proteinuria, we call it preeclampsia. But today, there can be, you cannot say that proteinuria is mandatory. So it is optional. So without proteinuria also, if again there is involvement of other organs, it can be preeclampsia. And only thing is definite, that is once there is convulsion, that is called eclampsia. That is the first thing a postgraduate should know. What do you mean by this and how to record a blood pressure? Second thing. So once you detect such a case, how to proceed? Clinically, you must know which are the higher risk groups of mothers who are likely to develop hypertension. So there are 1001 catalog of predictive tests, but none is ideal. None of them can be taken as a screening test for this hypertensive disorder of pregnancy. Therefore, FOGSI has come up with the gestosis guidelines. The symptom scoring 1, 2, 3. So there is a good number of clinical symptoms and signs basing on which we can mark it. If it is 3, that means the scoring is high. So therefore, those are the cases to whom you should focus. So how should you treat it? Before developing hypertension, remember my dear postgraduates, you can apply these prophylactic drugs. Once hypertension is established, there is no role of low-dose aspirin. So low-dose aspirin can be advised or advocated in those high-risk cases before development of hypertension, before recording of the hypertension. I still prefer 75 milligram. Even if today literature says 150 milligram per day, I still feel that it is 75 milligram. Next, when to start and when to stop. According to the severity from the past history, you can start it even from the very date of confirmation of the pregnancy. But ideally, after 12 weeks of pregnancy, you should start it and continue up to 34, 36 weeks because of the cardiac congenital anomalies may be there. Therefore, you should stop there or else it can be continued. Second is calcium. Yes, calcium in high doses, 1.5 to 2 gram per day, can be given earlier in pregnancy, 14, 15 weeks to be continued. That may act as just an accessory drug to low dose aspirin. That is the preventive aspect. Once it is diagnosed, irrespective of the trimester of pregnancy, when it is first diagnosed after 28 weeks, how should you treat it? Dear friends, my treatment, I divide it into 2 groups. One is the medical management. Second is important is the obstetrical management. In the medical management, first line of drug is antihypertensive. What antihypertensive do you want to prescribe? The pregnancy-friendly antihypertensive. So those antihypertensives which are contraindicated in pregnancy should not be given. So ideal drug on today's practice is labetalol. So start labetalol as soon as you diagnose that the mother is having blood pressure systolic 140 and diastolic 90, either single or both. Above than that, start it. Once you start these antihypertensives, that is labetalol, next is nifedipine. And methyl dopa is not the drug of choice in acute cases. In chronic cases, you can give it. Therefore, 2 drugs are available for practical purpose. One is labetalol, second is nifedipine. In emergency cases, in severe malignant hypertension, labetalol can be given also intravenously. That is the advantage. So that is about first drug is medical treatment is antihypertensive. My second drug will come as Maxal. So in case of severe hypertension, imminent preeclampsia, what are those conditions? Where a slightest delay may result in the complications like eclampsia or other organ failures, involvements. In those cases, you are bound to start Maxal. Magnesium sulfate is a life-saving drug. It can prevent major complications related to preeclampsia. So magnesium sulfate in the Pritchard regime, you can start it, keeping in view that the severity of the imminent eclampsia should be within control and you plan for delivery. There is no question of delaying the pregnancy weeks together once there is eclampsia or imminent eclampsia. So then when everything is settled by ultrasonography and other things, you plan for delivery, then continue magnesium sulfate 24 hours more extra after the date of delivery, time of delivery. So that is second drug in the medical management. Third one is the place of, I can say, antenatal corticosteroid. Because in most of the cases, in hypertensive disorders of pregnancy, particularly preeclampsia and imminent eclampsia, we are to iatrogenically, forcefully go for a premature delivery, or as such it ends in premature delivery because that is the nature's protection. So in such cases, there is no harm if you go for 2 doses of maternal corticosteroid, particularly betamethasone 12 milligram 24 hours or dexamethasone 6 milligram 12 hours. So that should be given during the antenatal period. Next question is obstetric management. As regards the obstetric management is concerned, if you are treating a case of hypertensive disorders of pregnancy, then first million-dollar question is when to intervene and when to allow the pregnancy. In mild cases, you can allow the pregnancy to term and even normal delivery. But in high-risk cases where there is a chances of imminent eclampsia, then you have to judge when to deliver, keeping in view on one side the risk and benefit of prematurity and the outcome, that is the maternal outcome also. So that depends on your ultrasonographic findings. Ultrasonographic findings has got 2 objectives. One, we can think of maternal conditions like involvement of the liver, subcapsular hematoma, even hydrothorax, ascites, renal problems, all these things can be known. And on the fetal compartment, we can know the gestational age, growth restriction, and amniotic fluid index. Apart from that, decision-making factor is the Doppler study. So when there is compromised Doppler study, you have to take a decision. So you have to take a calculated risk to deliver. So in that case, give antenatal corticosteroid and try to deliver if it is nearer to 34 weeks. So far, so good. And don't try to prolong the pregnancy to achieve from 32 to 34. By that, again, all the pathological conditions could have been multiplied in the mother and you may lose the mother as such. Next, my important question is management of labor. So management of labor is the mainstay to prevent the maternal mortality. So first stage of labor, second stage of labor, third stage of labor. The guidelines are during the first stage of labor, make it as painless as possible because slightest pain can increase the blood pressure, can increase the chance of convulsion. So epidural analgesia is the best. Epidural analgesia is the best, particularly in such conditions. And in the second treatment management is the management of the fluid. Fluid management in obstetrician and the postgraduates should be very much meticulous. They should be drilled that how to practice this fluid. The choice of fluid in these cases is nothing other than Ringer's lactate, Ringer's lactate, Ringer's lactate only. And Ringer's lactate, what should be your dose? I mean the speed or amount of the fluid you want to need. It is just a maintenance, 75 cc per hour. So that is the maintenance dose of the fluid, nothing more, nothing less. Because you know, now the mother is having extracellular fluid plenty, that from that compartment after delivery, that fluid again come back to the intravascular compartment, which can lead to a cardiac failure or anything else. So therefore, fluid management throughout the labor is very important. So then you go for estimation, assessment. Follow a patogram, particularly the labor guide which has been come up by the WHO now. So that will be very much ideal. So in such cases, so if you proceed to the second stage, the principle is cut short the second stage of labor. My dear students, underline this phrase, sentence, cut short the second stage of labor. How? If there is any fetal distress, forceps, if not ventus. So by that, mother will be relieved from the stress. So that is the advantage. No question of prophylactic ergometrins, oxytocin should be given in such cases. Allow the placenta to be delivered and always see if there is any bleeding more than from your visual impression that it is excess, go for uterotonics. So in that case, you have to keep a balance. Because if a hypertensive mother, preeclamptic mother loses normal amount of blood, she loses a gross volume of the hemoglobin that can, after delivery with hemodilution, or hemoglobin may fall from 15 gram% to again 7 gram%. Therefore, be cautious. So there was earlier the drilling with the postgraduates, what we are calling it medical venesection. In that medical venesection, 4 cups were tied to the 2 forelimbs. Gradually, we release one after another so that the venous return can be curtailed and controlled. So by that, we can avoid it. Once there is bleeding, there is no compromise. You can use any of your oxytocin. Third stage of labor is the most dangerous one. As I said, after the delivery of the placenta, once the fetal circulation is closed, that amount of 1 liter of fluid will come back to the maternal circulation. So therefore, you should be vigilant. The fourth stage, that is the golden hour, that is again the vital. If you lose 1 minute, you may lose the mother or the baby. Therefore, vigilant regarding the control of the fluid, intake output chart, antihypertensives, anticonvulsants, if it is going on, oxygen supply, supplementation. So everything that should be followed. And again, I can stress upon this, that if you find there is placental pathology is there is some retroplacental clot, then you can go for coagulopathy studies. So after that, observe the mother till in the labor room, till everything is settled. So she should be in the optimum observation in an ICU or in the recovery bed for few days till everything is settled, mainly 72 hours at least. Then measure blood pressure, urine for albumin, other baseline tests. Then she can be discharged with advice. What is the advice? The advice is both for the baby and the mother. As for the mother, one thing should be infused in her mind, that once she had got this hypertensive disorder of the pregnancy, chances in the second and subsequent pregnancies is more. That she should carry. Number 2, she should continue antihypertensive therapy under medical supervision up to 12 weeks. Then if it is normal, she can discontinue it. Then third, contraception is a must for spacing. So intrauterine device is the ideal contraceptive for the mother. That should be advised. And subsequently, please warn her that she may develop hypertension, she is susceptible for diabetes, and other medical disorders. So that should be kept in mind. My dear friends, so this is in the nutshell. As I have showed you, I said you to the postgraduates, I can show you the destination, but I cannot show you the path. Therefore, the tricks I have told you, now you analyze the theoretical aspects of it and find out what other things you want to add to my lecture and see it. In desperate situations, you may face in the labor room, you are quite helpless. The mother is convulsing, you are not able to control it. In such cases, there is nothing, you are totally hopeless. Then call your colleague, call your seniors. If not, pray Lord Jagannath. Oh Lord Jagannath, oh Lord Jagannath, you have saved Draupadi in the Kurusabha, and why not to me in the labor room? I am totally surrendered to you. Please save me, save my mother, save the baby. Thank you very much. Thank you for listening to me for a few minutes.
Dr. Vani?
Superb
Thank you,
lecture,
sir.
sir. It was a great insight, sir. You took us through the prevention and low dose aspirin, that is 75 to 150. I also agree 75, sir, because BMI of Indian patients are usually less, and accordingly that becomes 75 only. I also prescribe 75. And the role of calcium in prevention of hypertensive disorders, and you took us with the medical management, the labetalol being the first choice. Then we can use nifedipine and methyl dapa, which is not available nowadays. And then obstetric management was so wonderful. The first stage, we should go for the analgesia. Proper pain relief should be there, otherwise the blood pressure will be increased. Then cut short the second stage of labor. Fluid management, that is very, very important, because they have reduced the intravascular volume. And the partograph usages, the third stage of labor. Beautifully, sir, you have covered all. And the golden hour and the antihypertensive postpartum and the contraception. You have taken us through beautifully through these phases, sir. Thank you very much, sir, for great deliberation and great insights, sir. Thank you, sir. Pranam to you.
First of all, I would like to thank Dr. Archana Verma ma'am and Dr. Mala Srivastava, all the organizers, and Dr. Gangadhar Sahu sir for an excellent talk, sir. You have definitely given them the destination to my PGs. Your talk was excellent. You have very nicely depicted how the patient should be managed. One should have a high degree of suspicion if the blood pressure is more than 140 by 90 millimeters of mercury, and it should be repeated. And patient should not be left as such. Counseling plays a very important role. Patient should be told about that, how frequently she has to come, and whatever be the trimester of the pregnancy, the outcomes and counseling, they play a very important role, along with the dietary managements. The drug, definitely labetalol is the drug of choice. Along with that, what other drugs we should opt for depending upon the severity of the condition, be it preeclampsia, eclampsia, or simply gestational hypertension. So patient should be monitored at every stage, and especially the labor time. When the patient is about to deliver, the management of how IV fluids they should be given, how the patient should be monitored, when to cut short the second stage of labor, and along with that, the postpartum period. When maximum mortalities have been noticed, that at this time during the peripartum period, the monitoring is very important. Patient should be counseled regarding proper contraception, and definitely early mobilization should also be encouraged if the patient is having mild degree of PIH, because thromboembolism is also common among these patients. So thank you so much, sir.
Thank you.
Yes, definitely. Dr. Ganga.
Thank you, Dr. Rehana, for your expert comments. Now I invite Dr. Reenu Goel, our treasurer, West UP chapter ISOPARB, for conducting next session. Dr. Reenu Goel is consultant Ops and Gynae Ghaziabad. She has done graduation from GSPM Kanpur, post-graduation from Delhi. She is treasurer West UP chapter ISOPARB, associate member RCOG, coordinator IMA Shakti Ghaziabad, treasurer Women's Doctor Wing Ghaziabad. Dr. Reenu, over to you.
Hello. Hello. Thank you, Seema, for kind introduction. What teachers are the reason why ordinary students dream ordinary things. दिया ज्ञान का भंडार हमें, किया भविष्य के लिए तैयार हमें, है हमारी हम उन गुरुओं में, हम जिन्होंने किया कृतज्ञ आभार है. नमस्कार, डॉक्टर आशा, डॉक्टर उषा मैम, डॉक्टर संपदा मैम, डॉक्टर साहू सर, डॉक्टर अर्चना वर्मा मैम, डॉक्टर माला मैम. Good evening to all colleagues and delegates. I am Dr. Reenu. Now we are going to start our panel on case-based scenario in hypertensive disorders of pregnancy. For this, I invite as moderator हजारों फूल चाहिए एक माला बनाने के लिए, हजारों रंग चाहिए एक रंगोली बनाने के लिए, हजारों दिए चाहिए एक आरती सजाने के लिए, पर एक अच्छा शिक्षक जो कि का मित्र, साथी, दोस्त, सीनियर, जूनियर कोई भी हो सकता है, अकेला काफी है हम सबकी जिंदगी को सफल बनाने के लिए. अर्चना वर्मा मैम एज ए मॉडरेटर, Vice President FOGSI 2020, President FOGSI Best Committee Appreciation Award, Uttarakhand Governor Appreciation Award from CRPF, Abdul Kalam Excellence Award. Ma'am, you are now I invite Dr. Mala ma'am. गुरु ज्ञान का वो सागर है जो ज्ञान से हमारी जिंदगी को करता उजागर है. डॉक्टर माला मैम इज सीनियर कंसल्टेंट एंड प्रोफेसर GRIPMER, गायनी एंडोस्कोपिक एरोटिक सर्जन, सर गंगाराम हॉस्पिटल, न्यू दिल्ली. APG अब्दुल कलाम एक्सेलेंट अवार्ड, डॉक्टर सुभाष मुखर्जी वुमेन्स हेल्थ आइकॉन अवार्ड, Women Medical Professional Award. Ma'am, welcome you as a moderator in panel. I also invite Dr. Rehana. शिक्षक के पास ही तो वो कला है जो मिट्टी को सोने में बदल सकती है. Dr. Rehana, Professor and Expert, Head Ops and Gynae, TMMC and RC Moradabad. She is dynamic academician, always motivating PGs to work to achieve greater heights. She is very dear person in Ops and Gynae faculty. 31 publications in both national and international journal. Best paper in 16th conference of UP chapter. Ma'am, I welcome you all. Now I invite Dr. Mala to start the panel.
Good evening, everyone, and thanks, Dr. Reenu, for handing over for the panel discussion. I'm very happy that Dr. Archana Madam gave me this opportunity to moderate a panel with the youngsters. It's my pleasure to introduce my panelists for the evening, Dr. Maryada Jain, Dr. Tejasvi Papola, Dr. Jyoti Khatri, Dr. Varsha Chauhan, and Dr. Sapna Singh. I would request all of them to introduce themselves and say a few words.
Good evening, respected teachers. I am Dr. Maryada, postgraduate third-year resident in Department of Obstetrics and Gynecology in Tirthankar Mahavir Medical College, Moradabad.
Good evening, faculty members. I am Dr. Tejasvi from Ops and Gynae Department, and I am a third-year resident in Tirthankar Mahavir Medical College.
Good evening, everyone. I am Dr. Varsha Chauhan. I am doing my JRship from Tirthankar Mahavir Medical College, Moradabad.
Good
Dr.
evening.
Jyoti.
Good evening, teachers. I am Dr. Jyoti Khatri, third year junior resident in the Tirthankar Mahavir Medical College and Research Center. I would like to wish a very happy Teachers' Day to all the esteemed faculty present here.
And Dr. Sapna.
Good evening, respected teachers. My name is Dr. Sapna Singh from third year ObGy resident at the Tirthankar Mahavir Medical College at Moradabad.
My first case is a 30-year-old primigravida with 35 weeks pregnancy, comes to the OPD with the first reading of blood pressure of 140/90 millimeters of mercury. Dr. Maryada, what are you going to do? How will you proceed with this patient?
Ma'am, since this is the first reading, we'll ask the patient to sit and relax and take again the BP after 15 minutes in sitting or left lateral recumbent position. And if the BP is still 140/90 or high, we'll admit the patient, ma'am. And then after admission, we'll do strictly maternal monitoring and fetal surveillance. And in maternal monitoring, we'll strictly monitor BP after every 4 hours, but not between 10 p.m. to 6 a.m. Then we'll also do the urine dipstick test to look for proteinuria. We'll send all antenatal routine investigations, and in investigations we'll look for CBC, wherein we will look for hematocrit and platelet count. We'll send the coagulation profile, liver function test, where we'll be seeing the liver enzymes, and if the liver enzymes are raised, then we'll send for bile acids. In kidney function test, we'll be looking for uric acid. And we'll also send a spot protein creat ratio to look for proteinuria, and we'll ask for any impending signs of eclampsia. And in fetal surveillance, ma'am, we'll strictly watch for daily fetal movement counts and get the non-stress test done, which should be repeated 1 to 2 times per week. We'll also get the USG with color Doppler done, in which we'll firstly look for the presentation of the fetus, for the position of the placenta, and then we'll look for the parameters for biparietal diameter, abdominal circumference, or femur length to assess the fetal maturity. We'll also look for amniotic fluid index, and we'll also get Doppler done, where we'll be looking for umbilical artery, middle cerebral artery, or ductus venosus, and we'll calculate the cerebroplacental ratio. And USG should be repeated every 3 weekly for fetal growth assessment, and Doppler should be repeated every fortnightly.
Very good, Dr. Maryada. You have admitted the patient and you have investigated the mother, as well as you have done the fetal surveillance. Now, do you think this patient is severe or non-severe hypertension?
Ma'am, the patient is non-severe hypertension, because the severe features are like if the systolic blood pressure is more than 160 millimeter of mercury, or the diastolic blood pressure is more than 110 millimeter of mercury, if there is thrombocytopenia or deranged LFT or KFT, any features of pulmonary edema or new onset headache, or any visual disturbances.
So she is a case of non-severe hypertension. And you have thought of starting antihypertensives for her?
Yes, ma'am. The target BP should be 135/85 millimeters of mercury. So we can start the patient on the first line, that is tablet labetalol. We can start on 100 mg BD, ma'am.
Very good. Very good. So she is now 35 weeks pregnancy.
Yes, ma'am.
When are you planning to deliver her?
Ma'am, since there are no severe features,
admitted till term, no? She's 35 weeks, well controlled on labetalol. Now you can discharge her also. So when do you plan to terminate her pregnancy?
Ma'am, since there are no severe features, so we can prolong the pregnancy up till 37 completed weeks or up till 40 weeks, but not post date, ma'am.
Very good. So we are not going to take her post-dated.
Yes, ma'am.
We will plan her delivery. Now, this patient, She's a case of gestational hypertension. We plan to take her till term, but we may have to deliver her earlier if there are certain risk factors. Though this patient is 30-year-old, 35 weeks, and we are planning to take her up to term. But if in case there is other risk factors, then we may have to deliver her earlier.
Yes, ma'am.
So how will you deliver her?
Ma'am, ideally we can deliver her by vaginal route, vaginal delivery. If there are any severe features or if the BP is uncontrolled, then we can take her up for cesarean section, ma'am.
Cesarean section is done for obstetric reason.
Obstetrical reason.
Not because she's having hypertension. Okay. So we will induce her at term if she doesn't go into spontaneous labor, and we'll try to do a vaginal delivery for her. How do you manage her in postnatal period?
Ma'am, in postnatal period, we'll strictly watch for BP. Blood pressure charting should be done every 4 hourly. We'll watch for any impending signs of eclampsia. And in the postpartum period, ma'am, we shouldn't give injection methogen for PPH, basically. And to start on any antihypertensives, if the BP is controlled, then we can stop the antihypertensives. But if the BP is not controlled, then we can change the other antihypertensives, ma'am. And we can discharge her after her general condition is improved and BP is under control.
See, basically, in the postpartum period, also we need to watch very carefully, and we have to monitor her blood pressure even in the postpartum period. And once she comes after 6 weeks for charting or checkup, we have to repeat her blood pressure and see whether it's become normal or not. Very good. Now we go to the second case. Dr. Jyoti, a 37-year-old second gravida, para 1, no abortion, previous cesarean, presents to you at 8 weeks gestation. She gives history of previous cesarean done for severe oligohydramnios, fetal growth restriction, and preeclampsia. As a result, she had to be delivered at 32 weeks, and the baby weight was 940 grams. So how will you counsel her? How will you proceed? She has presented at 8 weeks of gestation.
Ma'am, my patient has her age 37 years old. She's more than 35 weeks. She preeclampsia in previous pregnancy with adverse outcomes such as fetal growth restriction, preterm delivery, and ma'am, severe oligohydramnios. I would like to evaluate further. I would like to take by her history. I would like to know what was the interpregnancy interval, ma'am, whether there was any history of obese PCOS, whether how was her blood pressure in the interpregnancy interval, is there any history of chronic hypertension, ma'am, whether her interpregnancy interval is of more than 10 years, ma'am, and whether she was on any other hypertensive, if she is a smoker, has any other stressor, or how was this pregnancy and the previous pregnancy conceived, ma'am, whether it was an assisted reproductive techniques were used, whether she has other history such as migraine, any other comorbidity such as diabetes mellitus, chronic renal disease, thyroid disorders, or any other autoimmune disorders, ma'am. This will further classify my patient, whether further I will look at the family history, if she has history of preeclampsia in mother and sisters, ma'am. Then further I will be examining her, ma'am. Further I'll examine her. I'll look at her BMI. If it is within the normal ranges, or if it is more than 35, she'll be a high risk patient, ma'am. I will further look at the mean arterial pressure also. How is her blood pressure at presentation, ma'am? I'll then calculate mean arterial blood pressure. If it is more than 85, she'll be a high risk pregnancy, ma'am. Then she has come to me at 8 weeks, ma'am. In further investigations, I'll advise her all the routine investigations, which will include her complete blood count, including platelets, urine routine microscopy, blood group, and ABO-RH typing, and then I'll look for the other viral markers, HIV, HCV, HPS, AG, and VDRL. Then her thyroid function test will be done. And ma'am, I'll have to here do a scan for localization of viability of the pregnancy. Then I'll have to further if the patient is willing, forward I will counsel her then how she has to come to me for follow up, and then I'll have to counsel her regarding the importance of her next investigations, which will be some other biochemical investigations which can be done in first trimester also, which is a ratio of angiogenic and anti-angiogenic factors such as platelet growth factor, PLGF, and soluble FMS tyrosine kinase 1, and I'll be looking at their ratio, and I can since we advise, I have to advise her for further follow-up, as we'll be doing ultrasound which will be for NTNB. With that I can look at the uterine artery Doppler and get a dual marker also, as Papa A will also signify the low values will also signify that she's a high risk pregnancy. And then ma'am, I'll have to counsel her regarding her home BP monitoring. I'll have to counsel her regarding how she has to watch for the impending signs such as headache, epigastric pain, and blurring of vision, ma'am. I'll have to counsel her regarding. I'll advise her a healthy lifestyle, and if she's obese, I'll have to counsel her regarding weight reduction, ma'am. And I'll optimize the other comorbidities if she has any. Then I'll be advising her low dose aspirin, which can be up from 75 to 150 milligram per day HS. I'll be advising her to take it at the hour of sleep, like at bedtime, because we expect BP to rise around 4 a.m. Then ma'am, I can, if she has history of low intake of dietary calcium, then I can add high dose of that is 1.5 to 2 grams of calcium also. Yes, ma'am.
Very good, Dr. Jyoti. See, 4 things we want to say. This patient had a hypertensive disorder in previous pregnancy. So she's a high risk for hypertensive disorder in this pregnancy as well. That is one thing. She had fetal growth restriction in previous pregnancy. So we are also looking for prevention of growth restriction in this pregnancy, because she has come to us at 8 weeks. So we have an opportunity to guide her. First visit, blood pressure is very important, and we have the opportunity to do Dopplers at 12 weeks NTNB scan and Papa A, as you said, during the dual marker. These are good predictive markers, and ecosprin as a prevention of preeclampsia as well as growth restriction. So 5 points are very important at this stage of pregnancy. Now we move on to the third case. A 38-year-old primary gravida, married for 1 year, presents at 8 weeks of gestation. Now she is having hypertension, essential hypertension already. Now she is very jittery, very apprehensive. She comes to her obstetrician. Madam, will I be able to carry this pregnancy carefully, successfully or not? Dr. Tejasvi, you are her treating obstetrician. How will you guide her? How will you counsel her?
Yes, ma'am. As this patient is having high risk factors like elderly maternal age of 38 years, and she is a primary gravida and also a known case of hypertension. The baseline investigations, baseline investigations of this patient has to be sent, including CBC, SGOT, SGPT, KFT, coagulation profile, and also ultrasound to be done for dating scan for localization of the gestational sac and also viability of the pregnancy. And if she is on any AC inhibitors or ARBs or diuretics, that should be stopped immediately after the confirmation of the pregnancy or on her first antenatal visit. It should be stopped immediately, and patient should be started on tablet labetalol 100 mg BD. And also at 12 weeks of, at 11 weeks of pregnancy, 11 to 13 weeks of pregnancy, during her NTNB scan, the uterine artery Doppler has to be done for the prediction of preeclampsia. And the patient should also be counseled for the level 2 scan and a repeat Doppler to be done at 28 to 30 weeks of pregnancy. And from the 12 weeks of pregnancy, she has to be started on tablet ecosporin 75 mg OD. And patient to be counseled for regular follow-up every 2 weeks till 32 to 34 weeks of pregnancy, and after that every weekly till the time of delivery. Yes, ma'am. And about counseling the patient should be counseled regarding the teratogenic effect of using ACE and ARBs during her early pregnancy, and also the exaggeration of the disease if the pregnancy is continued, and about the complications associated with this pregnancy, about maternal and also fetal morbidity or mortality, or the complications of preterm labor, IUGR, fetal deaths should be explained to the patient. And this pregnancy can be taken up to 37 weeks, 37 completed weeks. And about the postpartum care, the BP should be monitored every 2 hourly till first 2 days, and every BP should be monitored for the first 2 days, and at least once every third day, day 3 or day 5. And also the patient should be set for regular follow-up till 6 weeks of pregnancy, as the chronic hypertension as preeclampsia can come to normal blood pressures at 6 weeks of pregnancy, and if it extends after 6 weeks of pregnancy, it can be said as chronic hypertension.
Rightly said, Dr. Tejasvi, you have to impress upon this patient that she is an LD primigravida, and so she falls into the category of high-risk pregnancy. She is a case of essential hypertension that adds to her risk. Now she has to be counseled that she is a high-risk pregnancy. She has to be careful, and even her obstetrician has to be careful that she does not develop preeclampsia during the course of her pregnancy. We have to monitor her. We have to prevent growth restriction, and we have to prevent preterm labor, etc. in her case. So now we move on to the fourth case. Dr. Varsha, 28-year-old primigravida, presents at 24 weeks gestation with blood pressure of 180/100 and has severe oligohydramnios and fetal growth restriction. How will you counsel her and how will you manage her?
Ma'am, since she's a case of severe preeclampsia, we will admit the patient and we will try to control her BP by giving her injection labetalol lobate 20 mg start IV over 5 minutes. Simultaneously, we'll catheterize the patient, we'll do dipstick, we'll send some routine investigations like CBC, coagulation profile, LFT, KFT. Then we'll repeat her BP after 10 minutes. If her BP is still more than 160/110, we'll give her lobate 40 mg, and we will repeat her BP after 10 minutes. If it's still more than or equal to 160/110, we can repeat a dose of lobate 80 mg. Ma'am, simultaneously will give her magnesium sulfate according to Prachart regime. Loading dose will give 4 gram IV over 15 to 20 minutes and 10 grams IM over both the buttocks, 5 on each buttock. Loading dose, and then maintenance dose is 5 gram on alternate buttock up to 24 hours after the delivery, or the last episodes of fits, whichever is later. And we will counsel the patient regarding the poor maternal as well as fetal prognosis. We will counsel her to terminate the pregnancy.
Yeah, because this patient is having severe severe preeclampsia. She falls in the category of severe preeclampsia. She needs to be terminated because the fetus is only 24 weeks. We cannot wait for another 4 weeks for the fetal maturity and viability. So in the maternal sake, we have to plan and terminate the pregnancy. Next case goes to Dr. Sapna. 32-year-old, second gravida, para 1, previous cesarean, presents at 32 weeks gestation with umbilical artery S/D ratio of 4.5, AVI 8, and blood pressure of 150 by 100 millimeters of mercury. You are the treating obstetrician, Dr. Sapna. What will you do? How will you treat her?
First of all, we'll do the counseling to the patient about the risk of high blood pressure and our plan of management, risk of IUG, intrauterine growth retardation, risk of prematurity, and risk of preterm labor and low birth weight, and consequences of uncontrolled blood pressure, the risks of pre-eclampsia, risk of pulmonary edema and abruption, and impending signs of eclampsia. And then we'll try to admit the patient for fetal monitoring, workup, and corticosteroid cover. And altogether, first start with the antihypertensive medications to control the blood pressure. We'll, as the drug of choice is labetalol, we'll start with it. If the BP is uncontrolled, then we'll shift to second line drugs, and consequently, if uncontrolled, then we'll shift increase the drugs. And if still it is uncontrolled, then if it is uncontrolled, then we'll try to deliver the baby for the sake of maternal interest. As the period of gestation in our case is 32 weeks, so here we will try to save the life of mother and child both. So we'll try to save the first for the fetal lung maturity. In our case, we'll go for a corticosteroid cover where we can give injection betamethasone 12 mg 2 doses 24 hours apart, and or injection dexamethasone 6 mg 4 doses 12 hours apart. Then for the fetal monitoring, as we are saying that the SD ratio is 4.5, it means the systolic and diastolic ratio is systolic is much more higher. So we'll definitely look for the means there is a decrease in the umbilical artery Doppler in the diastolic flow. So here, in our case, we'll go for a weekly monitoring of the fetal growth, and we look for any where the growth of the baby is static in the next 3 weeks, or if any time if the growth worsens, then we'll terminate the pregnancy with the corticosteroid cover. In case if there is absent or reversal of diastolic flow, then we'll go for termination of pregnancy. In fetal monitoring, apart from the Doppler study, we'll also look for the biophysical profile, which most importantly, we go for the daily fetal movement counts, and also for the non-stress test, which can be done 2 times per weekly. And we'll also meanwhile send the blood investigations to rule out any organ damage, which will include the complete blood count, specifically when where we want to look for platelets, and the liver function test where we want to look for the liver enzymes, and the kidney function test also where we want to look for the creatinine values and coagulation profile and urine analysis. Also, we'll also look for the maternal any maternal deteriorating condition where we look for the decrease in the urine output, and we'll strictly monitor the BP of the patient. And along with this monitoring, we'll definitely counsel the patient regarding the proceeding plan for delivery, and accordingly.
Very, very nicely said, Dr. Sapna. So this is a patient who is 32-year-old, previous cesareans with raised S/D ratio and AVI 8, which is borderline, and BP of 150/100. We have to stabilize the mother, do regular maternal and fetal surveillance, and take action if there is absent end diastolic flow, or the biophysical worsens, or NST worsens, or daily fetal movement count is deranged. So we have to take action. She is a salvageable baby. We have to save the baby. We have to save the mother. Now we move on to the next case. Dr. Maryada, 25-year-old primigravida, presents at 34 weeks gestation of BP with 150-100 millimeters of mercury, severe itching all over the body, and damaged liver enzymes with low platelet count. How will you manage her?
Ma'am, this is a case of HELP syndrome, and the diagnosis of HELP is itself an indication for immediate delivery of the pregnancy, and the patient is more than 30 is at 34 weeks of gestation. So the delivery, so for the termination of the pregnancy is the only
we have to plan
management.
and terminate the pregnancy. Of course,
Yes.
before that, we'll have to stabilize the mother, see her baseline.
Investigation. Ma'am, we will look for a baseline platelet count and other investigations. And for minimum platelet
Very
count
important
required
is
for
PT and APTT,
PT, APT, yes, coagulation profile.
which is the coagulation profile, because we are suspecting HELP syndrome in this patient. So we have to know about the coagulation profile of this patient before we terminate the pregnancy. Otherwise, we'll be caught unawares and she will have massive PPH. So we do not want to land up into problems. We have a patient of HELP syndrome. We know we have to deliver her, but we have to deliver her with all precautions. We have to know her baseline, platelet, hemoglobin, PT, APTT, liver function, kidney function, and then we plan her termination. Termination can be done either by inducing the patient for vaginal delivery, and cesarean is done for obstetric reason. But we have to be ready with all our armamentarium. That cross match, FFP cross match, PRP cross match, and senior obstetrician as well as senior pediatrician managing the course of labor. Okay?
Yes, ma'am.
So we move on to the 7th case. 30-year-old primary gravida at 36 weeks gestation presents as at casualty with blood pressure of 190-120 millimeters of mercury with tonic clonic seizure. Dr. Jyoti, what are you going to do?
Ma'am, as my patient is a 30-year-old primary gravida with eclampsia, ma'am, I will, as I diagnose, I will immediately call for help. I will ensure that the patient is on the bed with rails. I will place her in the left lateral position to avoid aspiration. And if there are any, I will try to aspirate the mouth and throat. I will secure the airway and start oxygenation at 4 to 6 liters with mask. Then I'll have to look for her pulse rate, BP, respiratory rate, temperature, and level of consciousness, and auscultate for any signs of pulmonary edema also, ma'am. For her, I'll have to stabilize the patient. I'll have to manage a seizure, manage the blood pressure, and do fetal management. So once and these things I'll be doing simultaneously. I will ask my assistant to immediately secure wide bore IV line and send for ABORH, CBC, which will include platelet count, her coagulation profile, PT, APTT, and INR, her liver function and kidney function test, and simultaneously I'll have to calculate the take a history and rule out any contraindication to the drugs that I will be giving. So to control her blood pressure, I'll have to administer injection lobetalol, which will be 20 milligrams IV, and then for her seizure management, I'll have to give injection magnesium sulfate, which will be a total of 14 grams. I'll be giving 4 grams which will be 4 grams I'll be giving over 20 minutes. It will be a slow IV infusion. With that, I'll have to give a total of 10 grams. That will be 5 grams in each buttock. That can be combined with 1% lidocaine also, because it is a deep IM injection. Then I'll have to look for her blood pressure every 10 minutes and whether the seizures there is cessation of the seizures. So if my BP falls below 160 by 110 millimeters of mercury, if I'll have to monitor. But if it doesn't fall, then I'll have to administer the second dose of injection lobetalol, which will be 40 milligrams IV over 2 minutes, and then I can continue over next 10 minutes. I can give her 80 milligrams lobetalol or add another antihypertensive if my blood pressure is not controlling. If my seizure ceases, then I'll take her over to the maintenance dose of magnesium sulfate, which will be on the alternate buttocks every 4 hourly. But if it doesn't cease, ceases, then 2 to 4 grams of magnesium sulfate dose IV will be repeated. Then, ma'am, once my patient stabilizes, I have taken her brief history and I'll be doing an obstetric examination for my fetal management. I'll have to give her a dexamethasone cover also, or either I can give her betnisol. Then I'll have to plan the termination of her pregnancy. If the bishop's is favorable or not, I'll have to look if the delivery is anticipated within the next 12 hours. And if there is any, so I'll have to look if there is fetal distress. So if my cervix is unfavorable or there is fetal distress, or I'm not anticipating delivery within next 12 hours, or uncontrolled blood pressure, or if there is recurrent seizures or status epilepticus, I will have to do immediate termination of delivery, or either if my bishop's is favorable and I can plan vaginal delivery for her. For that, I'll be augmenting the labor either with prostaglandins or ARM followed by oxytocin also, ma'am.
Hello, Rehana ma'am, you can give some expert comments in between.
Yeah, definitely. I just wanted two comments from Jyoti. See, what are the contraindication of labetalol?
Ma'am, I have to look for signs and symptoms of pulmonary edema, which is a complication.
Labetalol should not be given in asthmatic patients.
As asthmatic patient, yes, ma'am, asthmatic.
Yes, and secondly, when you're giving Maxelf, how you will monitor?
Ma'am, I have to monitor by her respiratory rate, urine output, and her deep tendon reflexes. So if her respiratory rate, I have to look that it is more than 16. Urine output, she is maintaining that is more than 30 ml per hour. And I can monitor the deep tendon reflexes by knee jerks if they are present or not.
We can have expert comment from Dr. Rehana.
Yes, Dr. Mala.
We can have some expert comment. Your students
sure,
are doing brilliant.
No,
your students are answering very well.
It is,
they're taking the panel very nicely.
It's wonderfully designed case scenarios, madam. I really appreciate the hard work which you have done, and so nicely you have taken out each case scenario, right from preconception period to eclampsia and postpartum period. So nicely you are taking each and everything, chronic hypertension, how should we deal that? So I really salute to you the way you have conducted this panel discussion with my PGs. Basically, the level of questions was really high and they are doing it nicely. I really appreciate them also. And as you know, madam, that what I have seen, generally, what is the scenario that patient, they come to us at 7th month, 8th month, and for the entire period of their pregnancy, not even a single time their blood pressure has been taken outside. And it is so strange that actually this should be highlighted, that blood pressure monitoring is a very important part and that should be emphasized. Secondly, once we admit the patients, even with BP, say 150 by 100, 160 by 110, with proper bed rest and proper antihypertensives, many times we can prolong the pregnancy also of the patient, provided patient is not having other risk factors, like she's not having HELLP syndrome of severe degree, she's not having this thing, pulmonary edema, she is not having features of chronic renal disease. If these things are present and if it is a precious pregnancy, IVF conceived, then definitely it should be, the patient should be delivered at 32 to 34 weeks of pregnancy. And in case of eclampsia, if the patient is there, then besides the control of blood pressure, convulsions, counseling of the attendants is also important, that the patient will need a prolonged stay, she will need proper HDU or ICU management, for which many times the attendants, they are not willing, they say it's some upri chakkar, these kind of things also they come up. As we are in the periphery, our hospital is in the border of UP and Uttarakhand, so many times we people get such kind of scenes also, and that is all rest. You have conducted it so nicely, left nothing for me to say.
No, your children are managing the patients.
Thank you,
Your
madam.
students are managing
It's
the
your
patients.
guidance only.
So we have a last case scenario, 28-year-old para 1, delivered 4 days back. Now she's gone home and she's complaining of severe headache and reduced urinary output. Her BP is 160, 110 millimeters of mercury. Dr. Tejasvi, you have seen her in the casualty. How will you monitor her next?
Ma'am, as she is a post-delivery case with a BP of 160, 110 with severe headache and reduced urine output. This is a case of postpartum preeclampsia. And I will firstly admit the patient and send all baseline investigations, CBC, LFT, KFT, coagulation profile. And also will get an MRI or ultrasound, MRI and ultrasound whole abdomen plus KUB done in this patient. MRI to rule out hypertensive encephalopathy and subarachnoid hemorrhage or postpartum cerebral angiopathy, and ultrasound whole abdomen plus KUB to rule out any acute renal failure. And I will start the patient on antihypertensives like ACEs or ARBs. If the ultrasound and also investigations are normal, I can start. Patient can be started on prophylactic MGSO4. I will manage the patient accordingly, according to the investigations and also ultrasound and also MRI, ma'am.
Dr. Tejasvi, we have to impress upon here that since she is complaining of severe headache, we may have to do her CT scan. We have to, you have to understand, impress that patients complaining of severe headache needs either CT scan or MRI of brain, because in the postpartum period we are thinking of hypertensive disorders of pregnancy. She may be having sagittal vein thrombosis, central vein thrombosis also. That can also give rise to headache.
Hello. Yes, ma'am. Ma'am, in the pre-pregnancy counseling of a high-risk patient, first of all, the preconceptional care refers to the intervention.
Dr. Varsha. So, Dr. Sapna, you are going to give a pre-pregnancy counseling of high-risk patients.
Yes, ma'am. Ma'am, in the pre-pregnancy counseling, first of all, the pre-pregnancy care refers to the intervention that aim to identify and modify medical, behavioral, and social risk to a pregnant woman and her baby. So the preconceptional counseling is usually done under the 5 headings, that is preconceptional education first, second is the medical assessment, third is the screening, and fourth is the immunization, and fifth is preconceptional plan. So in high-risk patient, the preconceptional education, that is the counseling, plays a very important part, which includes a comprehensive like nutritional assessment for the overweight and obese patient and underweight patient, where the meal planning is being done, weight reduction, lifestyle modification, decrease in the alcohol consumption, increase in the physical activity, halt in the smoking, adequate sleep, reduction in the stress level is being played an important part. And along with that, especially in our scenario, like a hypertensive disorders of pregnancy, the patient should be counseled regarding the risk of superimposed preeclampsia, placental abruption, fetal growth restrictions also. In the medical assessment, we'll identify all the high-risk patients depending upon the pregnancy-related risk factors, where it can be a maternal age, which is less than 18 years of age or more than 35 years of age. In obesity, where the BMI is more than 30 kg per meter square, with the history of like smoking, multifetal pregnancy, the history of onset of preeclampsia and previous pregnancy, risk of pulmonary, if there is any history of pulmonary embolism and maternal complications associated with it, history of like epilepsy, a history of antidepressant medications, history of any hypertensive medication or diabetic medications or insulin, if the patient is on treatment, then there comes a history of any surgery past and history of childhood cancers, like we can say Bivens tumor, for example. And the perinatal outcome in previous pregnancy also plays an important role in counseling for the next pregnancy, also like fetal growth restriction, abruptio placentae, perinatal deaths, acquired thrombophilia, connective tissue disorders, and placental pathologies, if any, and along with the pre-existing medical conditions, like I have already told many, like otherwise renal diseases and antiphospholipid antibody syndrome, pre-gestational diabetes, maternal and many other risk factors. Along with that, the other thing, first of all, that is we'll try to screen also the patient meanwhile for all the comorbid conditions and the associated any complications associated with it, and we'll go for a baseline blood investigations to rule out all these, like blood grouping, blood sugars, thyroid profile, baseline ultrasonography to rule out any anatomical defects in the uterus or adjoining structures, basic urine analysis to rule out any proteinuria, as in our case, and otherwise, and in immunization, where we can specifically talk about the rubella vaccination, which also plays an important role. And after giving the rubella vaccination also, and it is said that one should at least wait for 1 month, at least for 1 month for conception. And like other immunization, like hepatitis B, influenza vaccines also. And the fifth part is the preconceptional plan, where a patient is specifically being counseled about the nutrition and supplementation, like folic acid supplementation, that is 400 micrograms should be started. Contraceptive counseling should also play an important role, where the birth spacing methods should be explained to the patient for the maternal benefits also, and general health of the patient should be counseled about, and like lifestyle modifications I have already discussed. And if any comorbid condition is being found, or there is any history of comorbid condition, then optimization should be done before proceeding for next pregnancy to prevent any adverse outcomes.
Very nicely said, Dr. Sapna. So with this counseling, we have to impress two things. One is optimum weight. Then we have to also see about the blood group, thyroid function, HPLC, then blood sugars. Then, of course, lifestyle modification that you have said, any drugs that she's taking already on, whether smoking or drug intake or any habits that she has to change. And definitely an optimum weight will go a long way in having a healthy pregnancy. We can have an expert comment from Dr. Rehana before we conclude our panel discussion.
So in the preconceptional period, this is the most important time. If a patient is coming to you and you are finding risk factors in the patient, she is having previous history of PIH, preeclampsia, or she is obese, or she is having history of epilepsy, then in that case, we must always optimize her mean body weight, her dietary habit, lifestyle modifications. If she is a chronic hypertensive, even blood pressure control is very important. The drug which should be started, and she should be counseled that she will need frequent hospital visits if she is planning her pregnancy. So this is very important. And besides this, what are the drugs which we should switch over to? If she urine pregnancy test, it comes out to be positive, and she's already on some antihypertensives, they should be immediately switched over to labetalol or nifedipine, whichsoever suits to the patient. If there is no contraindication to labetalol, like bronchial asthma, she's having any history of that, then labetalol should not be started. Even alpha-methyl-dopa is a very good drug. If it is used in a patient for hypertension in pregnancy, provided she is not having eclampsia or these kind of things, because it takes time to act. So labetalol is a very good drug. and definitely with proper counseling and proper antenatal maternal and fetal surveillance, the outcome of the pregnancy will be good. Thank you. It was very nice, Dr. Mala. Thank you so much.
I must thank all my panelists who have managed all the varieties of hypertensive disorder in pregnancy very nicely, very effectively, and giving a healthy baby and a healthy mother to our society. I thank Dr. Archana Verma to have given me this opportunity, and I thank Dr. Shubhra Agarwal also, who have helped me throughout planning this panel as well as executing this panel. And I thank Dr. Gangadhar Sahu as well as Dr. Reenu Goel and Dr. Vani and Dr. Seema Varshney, who have conducted this webinar very well. And thanks to each and every one of my panelists who have done a great job today evening.
Thank you, Dr. Mala, for wonderful panel discussion. It was very interesting, very informative, and very well conducted. And Dr. Rehana, your experts' comments were amazing. And thank you so much. And all panelists were very good. They have explained everything from head to toe. So thank you so much. And Dr. Shubhra, please give your official vote of thanks.
Give official.
चलिए, okay, I am giving. Dr. Shubhra, मैं आप सबका आभार प्रकट करती हूँ यहाँ आने का और इस वेबिनार को सफल बनाने का. Thanks to our great personality, Padmashree Dr. Usha Sharma ma'am, आप आए तो बाहर आई. Dr. Archana Verma ma'am, Dr. Sampathkumari ma'am, Vice President elect FOGSI. Dr. Mala Srivastava ma'am, आपने बहुत अच्छा कंडक्ट किया. आज पैनल बहुत अच्छा लगा, सब कुछ नया सब कुछ अच्छे से पढ़ाया आज आपने. डॉक्टर रिहाना मैम, डॉक्टर गंगाधर साहू मैम सर, थैंक्स टू डॉक्टर वानीपुरी, डॉक्टर पैनलिस्ट, ऑल पीजीज, डॉक्टर Tejasvi, Dr. Jyoti, Dr. Varsha, Dr. Sapna. Thanks to all of you.
Maryada, Dr. Maryada also.
Maryada, Dr. Maryada also. Thanks to Deepika, our co-host, and Jagsonpal Pharma Ltd. जाते जाते गुमनामी के अंधेरे में था बना दिया, उनकी ऐसी कृपा. बाय बाय, थैंक्स सबको, धन्यवाद.
Thank you, ma'am, and thank you, ma'am, all the panelists and the attendees for being here with us today. Jagsonpal presents to you Divatrone, micronized dydrogesterone, 10 mg tablets. We have Maintane injections, 31 years of Indian clinical experience, hydroxyprogesterone caproate 250 and 500 mg. LycoRed Preg sachets are L-arginine, lycopene, and DHA to prevent pregnancy complications, and Cyclorex CR10, controlled release tablets of norethistron acetate for freedom from menstrual irregularities.